We'll go over how to approach the diagnosis and treatment of these infections, and we'll discuss the current limitations to treatment of these diseases. And so we'll start off with some background. What's a filariasis? Anyone? What kind of organism is it? A little easy.
Filariasis.
Someone said worm. Good. Worm is good. And specifically, it's a nematode, right? So these are nematodes. They're tissue invasive. And then, what's the unbelievable part about it? What's that? It's that they are how do people get them? The bite. The bite of an arthropod. It's insane, right? Okay, there's my link. It's crazy. It's just like Prince throwing his guitar in the air. It's crazy. So, but it is insane, right? Like, when we think of arthropod diseases, vector-borne diseases, do worms pop into your mind? Not really, right? We think of things like Ebola and dengue and Zika and Chick and malaria. People don't think of worms. But actually, worm infections were the first organisms shown to be carried by arthropods. So filaria, it comes from the Latin root filum, like a filament, because they are thin, they're thread-like. So they're thread-like tissue invasive, round worms transmitted by insect vectors, and these are the organisms that cause it. So the first two are the causative agents of lymphatic filariasis. Onchocerca causes river blindness. Loa is the African eyeworm, where the worm actually goes across the front of the eye, but it doesn't cause blindness. It's just annoying. And then there are Mancinella infections. It doesn't really include dracunculus, which is the guinea worm. Some people will include it with filariasis, and some books do. I only include this for me because whenever I see a book that includes dracunculiasis, I'm like, look, it's like a different order. It's like way off. So anyway, that's just for me. So you don't need to know this one. The anatomy is complex. This is from a paper my lab published a couple years ago, and we included in this. We made this diagram of what the internal anatomy looks like, and we went over the anatomy of nematodes last week, so I won't go into it in detail, but this is an adult filarial worm, and they are long and thin. So if you take it in cross-section, you have the outer cuticle, and then you have, see, these are the nuclei of the epidermal cells. You see how they extend their cells outwards underneath the cuticle they're making? So they're kind of, the nuclei are underneath where, these are the muscle cells. So underneath the muscles, but they protrude through them to make the cuticle. So kind of interesting. And this secretory canal is that kind of primitive secretory system. But you know, not the anus, intestinal tract, and very large uterine tract. And within the uterine tract, the microfilaria develop. And they'll develop in eggs, and then as they transit down the uterus, they get more and more developed, and eventually they'll hatch. So typically these worms are viviparous. All right, Patrick Manson. Does everybody here love Patrick Manson? Yes? You should have trading cards of like the famous parasitologist. Manson should be there, right? That would be like the gold one. Because what did Manson do? What's that? So things like Schistosoma mansoni, named after Manson. So he was, so I'll share with you what he did. He was Scottish. Okay, so there are a couple of biographies about him, and so my information is from them. One of them was written by his son or grandson, so I'm sure put him in a very positive light. But I still like the stories, and a lot of the stories are true. So Manson was Scottish. Now I, having been born and educated in the United States, will never understand the United Kingdom, right? Like, is it one country, England, Scotland, like they have royalty? It's very confusing for Americans what's happening in the UK. But apparently, in the 1850s or so, if you were Scottish, the center of the UK was London. And if you were Scottish and you were a physician, and you wanted to work in London and make your mark, you couldn't just go to London. You had to go out into the empire and then come back, and then you could hang up your shingle in London. So what Manson did was he went to China. So he went to avoid China. And while he was there, in the 1800s, microscopy was really taking off in biomedical sciences. And it was known that if you take the blood of some people in the tropics, you could see little worms swimming around in the blood. It was also known that some people would develop these large swollen legs that looks like an elephant leg, and sometimes on autopsy, if you dissected someone, you could find these large worms, a few 4 to 8 centimeters long, it looks like a piece of floss, in their lymphatics. And nobody knew if those were related, right? These microscopic worms versus these macroscopic worms, and how's anyone getting them? So I don't know exactly what Manson's thought process was, but my guess is one day he was out there in China, and he was wearing a white shirt. I'm making this fun up. And he gets bit by a mosquito, and he smacks the mosquito. And what happens when you smack a mosquito? Blood goes up. And he's actually the first person to really have this insight. He said to himself, I wonder if those mosquitoes are picking up those microfilariae. So what did he do? Well, he had a helper with him there that he knew was microfilariae. This person had a lot of microfilariae in his blood when Manson looked at his blood under a slide. So this is true. Probably wouldn't be IRB approved today. But Manson tells Hinlo, hey, here's what you're going to do. You're going to go and you're going to go into this shack that we're going to build, and you're going to go to sleep in there, and we're going to put all these, I don't know what they used for like 1850s, torches, oil lamps, something, but some sort of light, and all the mosquitoes are going to come in to this hut, and then we're going to board up the hut, and you're going to blow out the lights, and you're going to let the mosquitoes feed on it. And Hinlo went for it. So they did this. They boarded this guy up in a hut with lots of mosquitoes feeding on him. Now the next morning, Manson came in with some other helpers, and they blew smoke into the hut, so all the mosquitoes dropped, and they opened the door and they said, Hinlo, you can leave now, you're done. And they pick up the mosquitoes, and they dissect the mosquitoes, and what do they find in the mosquitoes? Microbes. They find some worms. But that's pretty cool. But then the next thing Manson did was he didn't dissect all the mosquitoes. He put them into bell jars, and every couple of days dissected a different group. And what did he notice happen inside of the mosquitoes? They develop. So they actually grow tenfold in length in the period of about 12 days. The actual life cycle is absolutely incredible. These microfilariae get sucked up into the proboscis, and they go into the midgut of the mosquito. They penetrate the mosquito, and then they crawl out. And this is even the craziest thing. This multicellular eukaryotic animal goes intracellular into the striated muscle. Like, who knew mosquitoes had striated muscles? But they do have a little bit, because that's how they eat their wings. And they go intracellular, and they molt twice, and then they come out. And then when the mosquito is feeding, they drop out of their biting parts, and they wriggle into the bite. So Manson, here's a painting of Hinlo in the hut. And this is one of the most important experiments ever done in the history of medical science as we know it. Because it's the first ever demonstration that arthropods, and in this case mosquitoes in particular, can harbor infectious disease. Manson went on, he helped found the London School of Tropical Medicine. There is a book called Manson's Tropical Medicine that has now been in publication for well over 100 years. You can buy it today. And what else did Manson do? Well, once he was at the London School of Tropical Medicine, he had a disciple. That disciple's name was Ron Ross. And Manson said to Ross, you know, Manson was a big guy at this time. He said, I showed that mosquitoes can carry filaria. Maybe they also carry malaria. That was Manson's idea, and he told Ross that. And then Ross went to India, and he worked with avian malaria, and he eventually proved it. There are these great sets of letters from Ross to Manson about this. And Ross actually was awarded the second Nobel Prize ever in like 1901 or 1902 for that discovery. But Manson played a big role. So here's the general life cycle. This is true for all filarial pathogens. You should recognize filarial pathogens are common in life. I mean, it seems crazy, but basically every animal that lives on land and has a backbone, every vertebrate, so not just every mammal, but all birds and reptiles have filarial organisms that infect them. there are different arthropods that transmit them. So this is a very successful parasite. So the general life cycle is there's microfilaria. The microfilaria tend to be about 70 microns long, more or less, and about 3 to 5 microns wide. So about the width of a red cell, and somewhere, I can't do the math, but 20 times as long, something. So many times longer than a red cell, and about as thin as a red cell. And then these will circulate in the blood, or in the case of onchocerciasis, in the top level of the skin. An insect, or sometimes a different kind of arthropod, will then feed and take in the microfilaria or L1 stage. And within that arthropod, this will molt twice, generally over a period of 10 to 14 days until it becomes an infective stage. And then a subsequent bite results in transmission of that infective L3 stage. And it will get into the skin, and then in most filaria, probably rapidly escape by going into small vessel lymphatics. And then it will make its way to wherever it ends up. And different filarial species go to different places in the body. And I have some movies. So my lab has a couple, so I have a lab that studies filaria, and we have a couple filarial models. So here's what the adults look like. Now this is a rodent filaria, but really grossly it looks the same as human filaria. Should have tested it. There we go. This is when we first set it up. These are adult worms. Big. They're big, and they're big, and these are all from one rodent.
To adult Lemniscoides, same mouse.
And then, here are microfilaria. So this is a drop of blood unstained. You see the worm?
Yeah.
You want to see that?
Yeah.
This is a microfilaria.
That's just a big air bubble on the right.
It came from one of our Lemniscoides infected mice.
All the little circles are red cells, right? Some of the big circles.
It's at 100x2 microfilaria.
I was very excited.
Regular light microscopy.
Mostly because I tend to get excited, but that was 2006, and that's when I started the lab. And my whole lab was predicated on the assumption that we could get these life cycles going, and it took us about 9 or 10 months to get it going, and so I was nervous for a while because I was like, this is never going to work. But anyway, we're really the only academic research lab in North America that runs its own filaria life cycles. But that's what they look like. And you see those microfilaria, they're active, right? They're moving those red cells around. So what happens in the course of an infection? So we talked about how eosinophilia happens. And eosinophilia does happen, but what's interesting, and IgE responses. So when people get infected with filaria or any tissue-invasive worm, they will often present with allergic symptoms because essentially they're having an allergic response to the worm. But what this graphic shows is that over time, and really this is months to years, the allergic responses to the worm become attenuated. And if you look at endemic populations, they have very few allergic manifestations to the worms that they are infected with. And that is associated with a higher helminth burden. All right, so now I'm going to tell a story. This is a true story, and it's a good story. It's a good story because of its subject matter. What are the best stories about? Go in the back. Someone tell me.
Worms.
Yes, exactly right. Good. Flatter the speaker. That is exactly right. And there will be worms in this story. And a good movie, like you're going on a date, the best movies are about?
Romance.
Romance. Thank you. Yes. You're working with me. It's good. Some people like horror movies. I'm like,
Well, the date was the key part there.
what's that?
The date was the key part.
The date. I threw the date in is like, make it easier. So anyway, love and worms. And that's what this story is about. So I saw this patient. This patient had no symptoms. He had been going to the Central African Republic for years, for about 6 months out of the year, for years. And he came to clinical attention because a friend of his had a worm crawl across his friend's eye and was diagnosed as LOA. And then everyone on those expeditions was told to have their blood sent to be checked for LOA. I was at the NIH at the time, and Tom Nutland's group will frequently screen samples in the US for filaria. And so I was doing it at the time, and I got this purple top tube, and I look in, and this person who was asymptomatic had 6,500 worms in every milliliter of blood. Now I talked to this man, and I said, first of all, you have to tell me, why have you been going to the Central African Republic for 8 years? And he said, well, I mean, you can make stuff up, but yes, he said it was a girl. And he was from the University of Washington. He fell in love with this girl, but she was a PhD student in anthropology, and she kept going to the CAR to study the great apes. So the first year they're dating, she left him for 6 months. And he was sad. So the next year, he joined the expedition, and he got hired. Can't make this stuff up. He would actually build little towers and trees upon which they would put remote video cameras. And then, tragedy, they break up. But the silver lining is he had fallen in love with anthropology. So he applied and got into the same program. And that's why he'd been going there for 8 years. So that's a good story, right? But like now, he has these worms in his blood. So 6,500 in every milliliter of blood. What is completely bizarre about this case? Sorry, I just heard someone else, one person. What's that? Well, that's common. What's weird about this? No symptoms. No symptoms. Okay. Do we have anyone that's actually worked in a hospital in the last year? I'm going to ask you the easiest question. Okay, you have a patient gets admitted. They have a fever. I wonder if they have a bacteremia. Do they have a bacteremia? What test do you order? Blood culture. What's that?
Times 2.
Times 2, that's right. We want 2 distal sites, says the NIH. We get upset when we see one. So you get your 2 sets of blood cultures. That's annoying, because you have to send it to the lab, and they need to grow it. How come you don't order blood, gram stain, and culture? Because I want to know now. Why don't you have you ever thought about that? Like we do that for other tissue sites, gram stain and culture. Like CSF, gram stain and culture. Why don't you do a blood gram stain?
See if they'd be dead.
It's the sensitivity. Because we don't tolerate foreign organic material in our bodies. We do not. If you see bacteria on a gram stain of someone's blood, that person is septic in the unit. We don't tolerate it. The sensitivity is so low that we don't even bother staining. You take, you know how much blood we put into a blood culture bottle? It's 10 mils. You put 10 mils, you're just trying to catch 1 or 2 bacteria. When you take a drop of blood, it's maybe 5 microliters. So the sensitivity of catching things is very low. Yet we tolerate this. Is that not weird? I will tell you, it's completely bizarre. I should have played Matthew versus 1, but maybe I'll do that for free. All right, so so why does that happen? It happens because we develop tolerance to tissue-invasive worms, especially to filaria. It's pretty remarkable. So this is an old paper from 2003, but this is what kind of got me jazzed to go into this field, which is if we take white blood cells from a person infected with filaria, they've been infected for a short period of time, and you add filarial antigen to that culture dish, those T cells will proliferate and release inflammatory cytokines. But if they've been infected for months to years, that response goes away because they're tolerized. And interestingly, response to bystander antigens also goes down. So most people have been vaccinated with tetanus diphtheria, so you take some tetanus toxoid and you add it in, you see an attenuated response. And if we treat the worm infection, then those responses come back. And we know a lot of the mechanism here. Chronic worm infection turns on our body's brakes of the immune response. So people that are chronically helminth infected, especially with tissue-invasive worm, are immunoregulated. They have IL-10 and TGF-beta that are suppressing a bit parts of the immune response. And I'm not going to show you a lot of data from my lab, but I will show you this, which is there are these mice called nod mice. And because humans are just kind of intrinsically mean. These mice develop autoimmune diabetes, and decades ago someone said, I'm going to inbreed these mice. So now you can purchase these mice, and they almost always develop autoimmune diabetes. So they just have a few months to live. And they're easy to work with because we just purchase them from a company, we just house them, and if you just check finger sticks, over time, 80% of the female mice will have diabetes by high glucose, and they'll get really sick. If we infect, and this is due to autoimmune destruction of their beta islets in their pancreas, right? So juvenile diabetes model. If we infect with worm, and we can infect with different stages, different gender of worm, doesn't matter. If we establish worm infection, no diabetes. So the worm can exert a protective effect against autoimmunity, and likely a bit against allergies as well. And I'm on the immunology, but it's interesting. All right, to understand filarial infections of people, clinically, you need to know, I would say, the next two slides. So one is, where are they? Well, lymphatic filariasis is caused by Wuchereria and Brugia, and mostly by Wuchereria. And there's probably around 60 to 70 total lymphatic filariasis infections in the world today. Onchocerca volvulus is really just present in Central Africa now, almost none, if any, in Central America. And the numbers are kind of all over the board. Some papers will say 70 to 80 million, some will double it. And then Loa Loa is in Central Africa, and we probably won't have time to talk about Mancinella, but I have slides on those. So, do we have any of those in the United States? Lymphatic filariasis or onco or Loa? Not really, right? So, is there a filarial parasite that people in suburban Bethesda worry about? Not for them, but for a pet? Yeah, heartworm. You have heartworm, right? So, when you walk out this evening and you go into Bethesda to get dinner, if a mosquito bites you, there's actually a pretty reasonable chance that a little worm is going to try to make its way into your body. The thing is, we're not a dog or a cat, so it's going to up and die. Every once in a while, dirofilaria will cause a coin lesion in someone, because dirofilaria, the adult worms, like to go to the right ventricular outflow tract, but they're not really a problem in people. But we do have filarial infections in the United States. It's just we have zoonotic filarial infections. We treat, right? Anyone here have a dog? Give it your heartworm meds? Yeah. So it's usually ivermectin or ivermectin type drug. And essentially what you're doing is clearing out any worms kind of on a regular basis and preventing them from becoming adult worms. Because it's the adult worms that cause the problem here, because if you allow the animal to become infected with a large burden of adult worms, it can cause right ventricular failure, right heart failure, right? And then it's a problem to treat, because at this point you have this mass of worms, so when you treat the animal, it basically causes a large pulmonary embolism. So that's why it's tricky. So better to prevent. So that was one slide you need to know. And I would argue this is the most important slide. If you know this slide, you can zone out for the next hour and a half. Because this is really the crux of it. Like, you can figure out most test questions, honestly, from this slide. And so what do you need to know? You need to know where are the adult worms, where are the microfilaria, and when can you find the microfilaria? No joke, those three test questions will come from there. So, for lymphatic filariasis, Wuchereria bancrofti, Brugia malayi, the vectors are mosquitoes. The adults reside in the lymphatics. The microfilaria are present in the blood, and they exhibit diurnal variation, and they will peak at midnight. And they coincide with peak biting times of their preferred vector. For Loa Loa, the adult worms are in the subcutaneous tissues. They're always moving around. That's why people with Loa Loa have these calabar swellings, which are these transient angioedematous subcutaneous swellings. Oh, it's like on my arm, I get this swelling, and then the next day it's kind of at my elbow, and then it goes away. And then a month later, had something on my thigh, got swollen, seemed to move a little, then it went away. That's Loa Loa. You have adult worms migrating in the subcutaneous tissues. They release microfilaria. The microfilaria are also in the blood, but you need to draw the blood at noon, because this is transmitted by Chrysops flies. Their peak biting flies time is in the daytime. And then there's Onchocerca. Onchocerca is transmitted by black flies. We have black flies in the United States. We do not have Onchocerca volvulus, the main pathogen of humans, Onchocerciasis. Here, the adults also live in the subcutaneous tissues, but they don't move around. They nest and subcutaneous nodules. And emanating from those nodules are the microfilaria, which are in the top 1 millimeter of the skin. And so they cause people to itch. And when they crawl across the front of the eye, if they happen to die when they're crawling across the front of the eye, they can cause a little scarring that over the time, lots of little scars can coalesce, basically causes sclerosing keratitis. So this is the main slide for these talks. This is a paper I was a part of a few years ago, and it's more a thought paper than anything, but it's just, and you don't need to know it, but it's interesting. It basically talks about the concept that, that if you think about filaria and their hosts, one host can have lots of different filaria, but those filarial worms usually occupy different anatomical niches, and when they occupy the same anatomical niche, they'll sometimes occupy it at different times. And this kind of everybody finds their own little place to live in an ecosystem, that tends to occur in biology and evolution through something called competitive exclusion. So we talk about that concept with regards to human pathogens, filariasis within people. Okay, so this slide is a little complicated, but this teaching point is very simple. The teaching point is this. If you ever diagnose a person with any filarial infection, do not treat without speaking to an expert in the field. Okay? That's it. Don't look at a book. It's not algorithmic. Why is it not algorithmic? Well, the reason is the treatment of choice for lymphatic filariasis and loa is a drug called diethylcarbamazine. The problem is, this is the treatment of choice, but if a person happens to have onchocerciasis, DEC, which is a very good microfilaricidal, it kills microfilaria really well. In onchocerciasis, it kills the microfilaria too well, and the inflammation that arises in the eye can precipitate blindness. So you have to screen people that are diagnosed with LF for onco before you give them DEC. For loa, if a person, the treatment of choice is DEC, but if they have a very high number of microfilaria per milliliter of blood, you can actually kill them because you cause essentially this small vessel vasculitis. It looks clinically like an encephalopathy, but if people have really high MF numbers, which is usually over 10,000 MF per mil, but the guidelines say don't treat with DEC over 2,500 MF per mil, you can get this post-treatment inflammatory reaction to the dying worms that can result in death. So it's complicated, but basically the idea is, if you diagnose someone with any of these filarial pathogens, talk to someone in the field because they need to be evaluated for the other ones, and if they have LOA, you need to quantify the amount. Now, I used to think this wasn't a big deal to tell people because one cannot obtain DEC in the United States easily because no company makes it commercially in the United States. So even though it's been around for decades, it's not a big market for it. So when we obtain it, you have to go through the CDC on an IND. And the CDC will insist that you speak to someone in Tom Nutman's group before you give it. And I was like, that's a pretty good safeguard. I don't need to highlight this so much. Until about a year ago, when I was at a function, a school function, and I was talking to the dad of one of my teenage childs, a couple of teenage daughters, and one of their parents. I was talking, he's an emergency department physician here in suburban Maryland. And he said, Ed, because we chat sometimes, and he said, Ed, you're into worms. I'm like, yeah. He said, I had to tell you about this case. I had this woman come in, and she had a worm go across the front of the eye. It was loa, and she was from Central Africa. And I said, wow, what an interesting case. What'd you do? He's like, we treated her. And I said, you can't, how'd you get the DEC? And he says, that drug's impossible to get. None of the pharmacies, you have to go through and we looked it up, you have to call the CDC. What do you think they did? They told her just to call her family and have it sent from Africa. And so now I'm like, okay, I'm going to highlight this teaching point because I shouldn't do that. Okay, so now we're going to talk about some organisms. We're going to talk about lymphatic filariasis and a little bit of onco. Then we'll take a break. So, lymphatic filariasis, mostly 80 to 90% of the cases from Wuchereria bancrofti, 10% only in Southeast Asia from Brugia malaya and Brugia timori. The vectors are mosquitoes. Note, it's not just one genus and species of mosquitoes. And that's a little atypical. Most vector-borne diseases are pretty often, a lot of times vector exclusive, or just really have a preferred vector. But here, there are a lot of different mosquitoes that are permissive for the transmission of LF, which makes vector control a bit of a challenge. Hosts are human, the microfilarial bloodborne, the adults are in the lymphatics. There's really no reservoir for Wuchereria. For Brugia, cats and macaques can harbor them. So this is just where we have lymphatic filariasis. Notice that China has eradicated it. And they did that in part by adding diethylcarbamazine to table salt. And that can work. And I'm not going to go over this life cycle because we kind of went over the life cycles in detail. But mosquito. And then it gets in, it gets to the lymphatics. So how does it clinically manifest? It's interesting. Not everybody infected with lymphatic filariasis is symptomatic. If you look very carefully, you can find minor lab abnormalities in just about everyone infected. Like most people infected will have a little bit of microscopic hematuria. Interestingly though, really no association with renal insufficiency over time. Only about 40, 45, 50% of patients have disease. What's the disease? Well, the disease is lymphangitis, or including filarial fevers, and I'm going to talk about those in detail, and lymphatic obstruction. Those are the main diseases. And then this syndrome called tropical pulmonary eosinophilia, which I'll mention because it's testable, but it's really rare. So what are the clinical manifestations? Well, classic filarial fever is a lymphangitis, an inflammatory response against the worm. And the unique part of this is that it's a retrograde lymphangitis. So the redness started here, and then it went down. And that's very unique. There's no other organism or pathogen I know of, right, that causes a descending lymphangitis. It's usually ascending. That's a response to the worm. But that's not the cause of most lymphangitis. And we'll talk about that in a bit. But most lymphangitis is just bacterial skin and soft tissue infection. And then we can get dysfunction of the lymphatics. So the lymphatics play a large role in uptake of extracellular fluid, right? And so when the lymphatics are dysfunctional, we get accumulation of excess extracellular between the cells interstitial fluid. And so, for example, hydrocele is very common. It's about, the numbers are kind of all over the place, but they have a pretty good sense. There's somewhere like 20 to 30 million people in the world suffering from hydrocele. And hydrocele can be terrible where a person really is dysfunction from it, but most of the time, it's this size or maybe a little bigger. The person has normal genitourinary function, normal sexual function. But this tends to hit people in their late teenage years, the hydrocele, and it's very morbid because it's very socially isolated. And a lot of studies have been done that hydrocele that develops due to lymphatic filariasis really results in people don't want to marry these people, often excluded from their society, so it's a sad disease. And then there's lymphedema, and lymphedema can be mild, but of course it can progress. And it can get to the point where someone's limb really looks like an elephant's limb, thus the term elephantiasis. Most of the time, hydroceles, it's just due to an accumulation of interstitial fluid because the lymphatics are dysfunctional. And so if you were to tap this, you see serous fluid, right? Every once in a while, lymphatic will rupture, and then you'll get a frank chylocele. But that's the minority. There's lymph fluid spilling into the cervical side. Todd Gleason is an infectious diseases doctor, actually here at Walter Reed in Bethesda. And he went on a humanitarian mission on the USS Comfort a few years ago with the Navy. This is probably 7 or 8 years ago now. And he went to Haiti. And if you looked at the top half of this young man, he's a beautiful young man. But if you look at his bottom half, it's just completely disfigured. And it's disfigured by a disease that can be avoided by just giving him filarial medications that cost like $1/4 once a year. But this is what lymphatic filariasis can do. And so this still happens today. And it's just a devastating disease. So this was in 2000. My lab actually established a ferret model. Most of the rodent models, or none of the rodent models, mimic human disease. So if we take human Brugia and we infect the ferret, this side got infected, this side didn't. And 4 months after infection, we're able to color the lymphatics I add in a dye that binds to albumin and injecting it subcutaneously. So these are the lymphatics. And what you see, we just opened this animal. There was no dissection. And when you just open the animal, you immediately see that you have these dilated lymphatics, and it's more easy. I don't know that they proliferated. I think they just enlarged compared to this side, which was not infected with bruising. And then you can actually, I don't know how well it'll come out here, but this is intralymphatic filariasis. So this is that same animal, and someone in my lab just took a video with their iPhone. Do you see the worms? See, the worms are in the lymphatics. And these areas of constriction, that's where there are valves, because lymphatics have valves. They also have a muscularis that beats. They have their own pacemakers. So I'll show you that again. We're just going to submit this for publication this month. But this is really kind of the world's only animal model at the moment of true intralymphatic filariasis. The worms actually go across the valvular spaces. And you see more dilation where there are worms than when there aren't worms. It's interesting, histologically, we see more inflammation in the areas where the worms are not. So that's intralymphatic filariasis. Now, why does it cause the lymphedema? Nobody really knows. Certainly, they cause valvular incompetence. They go across the valves. But there's also probably a component of inflammation. I told you that people tolerize to worms. Not everyone tolerizes. The people with the lymphedema tend to have the most robust inflammatory responses to worm antigen, and they tend to have the least number of microfilariae. So it's kind of like if you tolerize, you protect yourself from disease. But it's worse for the population at large, because now you transmit it to mosquitoes. Does that make sense? The people that develop a stronger inflammatory response seem to be the ones that maybe scar down their lymphatics. And then we can repeatedly infect so that we can actually get clinical disease in the parents. And then this is interesting. Clinically, lymphedema and lymphatic filariasis takes years to arise. We don't see this in little children. Maybe we'll see it in 11, 12-year-old, but really not too much earlier than that. So the process probably takes a long time, but the dysfunction starts very early. So this is from the same study of ferrets, and we developed a PET-CT model to do lymphoscintigraphy. So we inject a tracer into subcutaneous tissues and look to see where the tracer gets taken up in the lymphatics. So here's normal ferret lymphatics in an uninfected ferret. And this is the same ferret 2 weeks later after infection. The worms haven't even become adults yet. And what do you see? You see dilation of the lymphatics and the development of collaterals. And what we've imaged here is 10 minutes of continuous imaging collapsed into one frame. And here at the 8-week time point, you can see that even though this animal did not have clinical lymphedema, they worked well enough to bring the fluid up. And remember, it's not just the lymphatics, but also the venous circulation will return interstitial fluid. So even though this animal wasn't clinically symptomatic, we see a dramatic decrease in lymphatics. And then we can do this in a quantitative fashion as well. All right. Then there's tropical pulmonary eosinophilia. I just have one slide on it. It's called TPD. Here's the story. A person lived in an area where there was lymphatic filariasis. They grew up there. Now they move, they go to Canada. There's not a lot of, there's no lymphatic filariasis. People in Canada. They live as a pharmacist in Canada. They're there for 20 years. They go back home to visit relatives to an area in India where LF is still endemic. They do fine. They come back to Canada. They're still fine. But 2 or 3 months after returning from their trip, they develop severe nocturnal asthma with very high levels of eosinophilia. So this is a presentation of acute, severe nocturnal asthma in adults that didn't have asthma before, with a very high eosinophil level. And most of the time, these patients, I imagine, are just treated for asthma. And if you do that, they'll be fine. It's not like strongyloides where you get a hyperinfection syndrome. And they'll respond okay to the asthma medicines. But what they really are having is a hyperinflammatory response to the microfilaria as they circulate through the beds of the lung. And these people, if you get filarial antibody titer, it'll be sky high, and they'll respond very nicely to antifilarial therapy. This is just a reminder of the diurnal periodicity of the microfilaria in the blood. So you really do a midnight blood draw if you want to find microfilaria. People always ask, are they jet lagged? The answer is yes. The worms jet lag. But if someone's been back in the United States for a couple of weeks, the worms then are back on, whatever time they're in. So how do we diagnose it? Well, we can diagnose lymphatic filariasis if we find microfilaria in a nighttime blood specimen. You can do that by microscopy, but generally you'll want to do something to filter the blood so you don't just look at a couple milliliters. So usually we'll just take 10 or 20 milliliters of blood and push it through a filter that's has 3 to 5 micron wide pores. Now here's the thing, we have now developed, and it's been around for a while now, an adult antigen test. Because these worms, while they live in the lymphatics, they release their antigens and it gets from the lymphatic system to the blood. And so this antigen is always present in the blood. And it just takes a couple drops of blood. And so it's really easy. Now, it's not approved anywhere, but the NIH will do it for you if you send them blood. And you don't, it's really nice because you don't have to do these midnight blood draws. And then research labs can do nucleic acid-based testing. In the United States, a lot of times for filarial infections, we will be unable to make a definitive diagnosis. But if we see filaria serology positive with a consistent clinical picture, we'll make an empirical diagnosis. And again, this is the number of the Nuttman lab. You just call them up, and they'll do your filaria antibody testing. Now, in the United States, the recommended treatment is diethylcarbamazine for 12 days. That's what's recommended by the CDC. If you give one dose, it's only microfilaricidal, but if you give a couple of weeks, you're probably killing a lot of the adult worms. So, most people haven't heard of diethylcarbamazine. I mean, people heard of it? It's a pretty good drug for filarial infections. The mechanism of action isn't really known. It's not directly toxic to the filaria, so it probably harms them somewhat when the immune system comes in and wipes them out. It's well absorbed, half-life is about 8 hours. Now, the problem with DEC is that, as we mentioned before, it can cause problems in people that have low IMF count or people that have onchocerciasis. And when you treat lymphatic filariasis, people that have a lot of microfilaria might have a transient lymphangitis as a response to dying worms. So I'm guessing nobody knows this person. The person who discovered DEC. But I like talking about this person because it's interesting who we know about and who we don't know about. So the man's name is Yellow Brigada Subaru. Like, no one's heard of this, right? Like, who's heard of Yellow Brigada? But it's kind of ridiculous. We should all be naming our children Yellow Brigada. Because this guy, he was pretty awesome. Not everything, I mean, his scientific discoveries were awesome. And again, the autobiography I read about him was read by someone who's a real fan. So take it all with a grain of salt. But here's his story. He was born in India in 1895. Now, he didn't love school. And in his autobiography, apparently he used to run away from school and play hooky, and his mother used to send his older brothers out to grab him and bring him back to school. But eventually he became quite the academic and the scholar, and he went to medical school. And in medical school, he used to wear a particular dress that showed that he had solidarity with Gandhi's independence movement. The medical school at the time, of course, was run by the English, and they didn't like that. And even though he scored superior marks, he was given a lower degree because of his association with the independence movement. So he married a young woman and was able to get her uncle to pay his way to the United States. And then he never went back to India or this woman again. And so, a year ago I was telling people about this story and someone was like, Dr. Petrie, this is your hero? And I'm like, look, who am I to judge, right? But listen to what he did. He gets to the United States, and he gets to Harvard, and he joins the lab of Dr. Cyrus Spiss. When he's there, he had to work 2 to 3 other jobs to make ends meet, including working on, cleaning the floors of the university just to survive. He was at Harvard. This is the craziest thing. For over 10 years, where he made some important discoveries I'll show you about on the next slide, he was never granted tenure. Eventually, Letterly Labs said, oh my gosh, we have this brilliant biochemist, and they hired him for 8 years. He had been over 20 years in the United States making incredible discoveries. He was never even given a green card. So what did he discover? Let's go through. Okay, he joins the lab of Cyrus Fisk. It was a biochemistry lab. And at the time, a Nobel Prize had been given to a group that had shown glucose is the currency of energy in a cell. Is that true? What's the currency of energy in a cell? ATP. You know who discovered that? Filariasis showed that in a science paper. So he discovered that. Then he developed a method to synthesize folic acid that still bears his name today. And because he was studying the folic acid cycle, he discovered inhibitors of folic acid. Methotrexate. Has anyone ever prescribed methotrexate? You give it all the time as a steroid-sparing agent. You know who discovered it? And I'm not making this up. This is documented. Filariasis discovered methotrexate. And he did all that at Harvard. And they did not give him tenure. So who am I to say why? But anyway, so then Letterby Labs sees this biochemist and the papers he's published, and they say, okay, people are being ridiculous. And they hire him and basically tell him, we're going to give you a team and a lot of money, and we want you to discover stuff for us. And he did. One of the things he discovered in 8 years, he discovered ethylcarbamazine, and he led Benjamin Huber in the discovery of aureomycin, which was the world's first tetracycline. So I would argue any one of those discoveries is Nobel Prize worthy. He had 4 of them. It's really astonishing what you come. Okay, so back to LF. We talked about LF and filarial fevers. Some people get these febrile lymphocytosis and lymphangitis. But that's not usually the problem. The problem isn't usually inflammation against the worm. What happens is skin and soft tissue bacterial infections. If I get edema of my leg, what happens to my skin? The skin becomes taut, right? It becomes tight. Now usually if I'm walking around and I bump into something, I have some give. So this isn't going to rip very easily. But if it's blown up tight like a balloon, any little trauma, I'm going to get a little cut. So now I have a portal of entry for skin flora, mostly bacteria. And when the bacteria come in, because my lymphatics are dysfunctional, it's going to be harder for me to clear the infection. So what happens in lymphatic filariasis is people get recurrent bouts of skin and soft tissue bacterial infection. And it's the inflammatory response that's trying to clear those that results in that soft tissue remodeling, which gives you that elephant leg appearance. That elephant leg is not fluid and lymphedema. It's restructured soft tissue. There is nothing to drain there. Does that make sense? And this is really a disease of recurrent skin and soft tissue bacterial infections. And we know that in part because in the United States, we resect lymphatics, right? Like someone has breast cancer, they get a lymphatic resection. They'll develop lymphedema, but they'll never develop true lymphangitis of that arm because as soon as they get a cellulitis, we're on it. Does that make sense? So in the filarial world, we divide inflammation against the worm and inflammation against bacteria into 2 different names. But they're both just descriptive. Acute filarial lymphangitis versus acute dermato-lymphangitis, which just means acute inflammation of the skin, lymph nodes. And probably when people have inflammatory events of their limbs, 97% of the time, it's the bacteria. And this was really advocated and shown in large part by Garusid Ryer, who's a scientist in Brazil. In areas of northern Brazil, they still have a little bit of lymphatic filariasis. And she makes the point that if you have someone with lymphedema, not really of any kind, but including lymphatic filariasis, you want to elevate the limb, you want to do hygiene, wrap it with ace bandages, and be very, very vigilant about treating soft tissue bacterial and fungal infections. And then, have you all heard of the global program to eliminate LF? So this is the largest ever in the history of the world as we know it, the largest ever single organism eradication campaign. There's over 70 countries involved, and the goal is to treat well over 1 billion people for 5 to 7 years with anti-lymphatic filariasis medicine. It's been going on since the year 2000, 2001, and we think we've dropped the prevalence from about 140 million infected patients to about 60 to 70 million infected patients. And the ideas behind it were that It's hard to get this infection. This is not typically a traveler's infection. Lymphatic filariasis, one usually has to be exposed to mosquitoes for quite a while before we get infected. For Filariasis, there's no reservoir in the wild, and treatment is effective for the microfilaria. Now, we don't have great treatment that we can give a single dose to kill the adults. And so essentially, the strategy is you identify countries at risk, and then what you do is you give single dose, usually of DEC combined with another medicine, ivermectin or albendazole. And that'll drop your microfilaria for many months. And then you just keep doing that, like twice a year for 6 years. Essentially, you've interrupted transmission. So it's a transmission interruption strategy. Skip this. Up until 2014, there have been over 5 billion treatments administered, over 1 billion people treated, and 55 countries of 73 that were endemic were involved. So it's a pretty impressive strategy, and a lot of effort being put into it. And then this is the newest thing in the eliminating lymphatic filariasis front, which is if you combine DEC, albendazole, and ivermectin, you can probably decrease microfilaremia for over a year. And so in areas where it'll be safe to give DEC, which is basically areas where there isn't LOA, the WHO is thinking of adopting this strategy because maybe you don't need to go back to these communities quite so often to get elimination. Let's take a break, and when we come back, we'll do aqua and LOA. Sound good? So let's take like